HIV undetectable equals untransmittable, U equals U clinical implications, management, and counseling. The U equals U paradigm, supported by greater than 10,000 person-years of follow-up, demonstrates that a sustained plasma HIV-1 RNA less than 20 copies/ml eliminates sexual transmission risk, 0% transmission. This effect is mediated by antiretroviral therapy, ART, that suppresses viral replication at the cellular level, preserving CD4 T-cell immunity and reducing genital tract viral shedding. Diagnosis hinges on quantitative HIV-1 RNA testing, limit of detection less than or equal to 20 copies/ml, and confirmation of ART adherence greater than or equal to 95% via pharmacy refill data. First-line integrase strand transfer inhibitor, INSTI-based regimens, such as bictegravir/emtricitabine/tenofovir alafenamide, BIC/FTC/TAF, 50 mg/200 mg/25 mg daily, achieve undetectable viral loads in greater than 95% of patients by week 4, forming the cornerstone of U equals U counseling. Key points. Note: sustained plasma HIV-1 RNA less than 20 copies/ml, the assay limit of detection for most commercial PCR platforms, confers a 0% risk of sexual transmission, 95% CI 0.2%. HPTN 052, Partner 2, and opposites attract studies. First-line INSTI-based triple therapy, e.g., bictegravir 50 mg plus emtricitabine 200 mg plus tenofovir alafenamide 25 mg daily, achieves viral suppression in 96% of ART-naive adults by week 4, ACTGA 5353. ART adherence greater than or equal to 95%, greater than or equal to 0.95 proportion of days covered, is the threshold associated with durable undetectability. Less than 80% adherence raises the odds of virologic rebound by 4.3-fold, COBRA cohort. The WHO 2023 guideline recommends initiating ART within 7 days of diagnosis for all individuals, regardless of CD4 count, to achieve U equals U as early as possible. In pregnant women, tenofovir alafenamide 25 mg plus emtricitabine 200 mg plus dolutegravir 50 mg daily is safe, Category B, and results in maternal viral load less than 50 copies/ml in 98% of cases by delivery, Impact 2010. Renal dose adjustment, tenofovir disoproxil fumarate, TDF, 300 mg daily is contraindicated when eGFR less than 30 ml/min/1.73 square meter. Switch to TAF 25 mg daily or abacavir 600 mg daily if HLA-B5701 negative. Hepatic impairment, bictegravir exposure increases 1.5-fold in child Pu-B. DOS remains unchanged but monitor ALT/AST weekly for the first 12 weeks. In patients greater than 65 years, the Beers criteria list efavirenz 600 mg daily as a potentially inappropriate medication due to neuropsychiatric adverse events. Prefer INSTI regimens. U equals U counseling reduces condomless sex anxiety by 68%, meta-analysis of 12 RCTs, 2022, and improves ART adherence by 12%, p equals 0.03. The cost-effectiveness threshold for universal ART is $1.800 per quality-adjusted life-year, CALI, saved, well below the WHO ceiling of 3 times GDP per capita for low- and middle-income countries. Genital tract HIV RNA correlates with plasma VL, R equals 0.84, p less than 0.001, when plasma VL less than 20 copies/ml, 99% of GENET. Overview and epidemiology. The International Classification of Diseases, 10th revision, ICD-10, code B20B24 designates HIV disease, with B20 specifically for HIV-1 infection. In 2023, an estimated 38.4 million people worldwide lived with HIV, of whom 23.5 million, 61%, were on ART, and 19.2 million, 50%, achieved viral suppression, less than 200 copies/ml, UNAIDS 2023. Regionally, Sub-Saharan Africa bears the highest burden, is almost equal to 20 million PLWH, while North America and Western Europe together account for is almost equal to 2.1 million PLWH with a suppression rate of 84%, CDC 2022. Age distribution shows a median diagnosis age of 31 years, IQR 2438, in high-income countries, versus 27 years, IQR 2233, in low-income settings. Sex-specific prevalence is 0.3% in men and 0.22% in women globally, but among men who have sex with men, MSM, the prevalence rises to 12.3%, RR is almost equal to 40, CDC 2022. Racial disparities persist. In the United States, Black/African American individuals represent 42% of new diagnoses while comprising only 13% of the population. RR is almost equal to 3.2. The annual economic burden of HIV in the United States is $45 billion, comprising $20 billion in direct medical costs and $25 billion in indirect productivity losses. Kaiser Family Foundation 2022. Globally, the cost of ART per patient averages $150 per year in low-income countries and $200 per year in high-income countries. WHO 2023. Modifiable risk factors include condomless anal intercourse, RR equals 4.5, injection drug use, RR equals 3.2, and untreated sexually transmitted infections, RR equals 2.1. Non-modifiable factors comprise male sex, RR equals 1.3, African ancestry, RR equals 1.5, and genetic polymorphisms in CCR5, delta 3-2 heterozygosity confers a 0.6-fold risk. The U equals U concept emerged from 3 landmark trials. HPTN 052, 2009, demonstrated a 96% reduction in transmission with ART. Partner 1, 2016, reported 0% transmission among 888 serodiscordant couples with VL less than 200 copies/ml. Partner 2, 2019, confirmed 0% transmission. Pathophysiology. HIV-1 is a retrovirus that infects CD4 T lymphocytes, macrophages, and dendritic cells via the CD4 receptor and coreceptors CCR5 or CXCR4. Binding triggers GP120-mediated conformational changes, exposing the V3 loop and facilitating fusion through GP41. Reverse transcription of viral RNA into proviral DNA is catalyzed by reverse transcriptase, RT, a high-error enzyme that generates a diverse quasi-species pool. Integration into the host genome via integrase establishes a latent reservoir, primarily within resting central memory CD4 T cells. Median half-life is almost equal to 44 months. ART achieves undetectability by interrupting the viral life cycle at 3 critical nodes. 1. Entry inhibition, e.g., Maraviroc 150 mg BID blocks CCR5. 2. Reverse transcription inhibition, e.g., tenofovir alafenamide 25 mg daily, a nucleotide RT inhibitor with intracellular tenofovir diphosphate concentrations 4-fold higher than TDF. And 3. Integration inhibition, e.g., bictegravir 50 mg daily, a potent INSTI with IC5 is almost equal to 0.5 nm. By suppressing plasma viremia to less than 20 copies/ml, ART reduces the number of infected CD4 cells entering the circulation, thereby lowering genital tract shedding to undetectable levels in 99% of cases. Miller et al., 2021. Clinical presentation. In the era of universal testing, most newly diagnosed PLWH are asymptomatic, with 68% identified through routine screening rather than clinical illness. When symptoms occur, they follow the classic acute retroviral syndrome (ARS) timeline: fever, 62%, maculopapular rash, 48%, lymphadenopathy, 55%, sore throat, 41%, and myalgias, 38%, within 2-4 weeks post-exposure. The prevalence of ARS has declined to 22% in the ART early era, reflecting earlier detection. Atypical presentations are more common in older adults, greater than 65 years, and individuals with comorbid diabetes mellitus, where fatigue, 71%, and weight loss, 57%, may be misattributed to chronic disease. In immunocompromised hosts, e.g., organ transplant recipients, opportunistic infections such as pneumocystis jirovecii pneumonia can present with nonspecific dyspnea and hypoxemia. CD4 counts less than 200 cells/L carry a 12% 30-day mortality risk if untreated. Diagnosis. 1. Screening. Perform a 4th-generation HIV-Ag/AB combination immunoassay, e.g., Abbott Architect HIV-Ag/AB, sensitivity equals 99.9%. 2. Confirmatory testing. If reactive, confirm with an HIV-1/HIV-2 differentiation assay, e.g., Genius, specificity equals 99.8%. 3. Quantitative viral load. Use a nucleic acid amplification test, NAAT, with a lower limit of detection, LOD, less than or equal to 20 copies/ml, e.g., Roche Cobas Ampliprep/Cobas Tacman, CV equals 5%. 4. CD4 T-cell count, flow cytometry, normal range equals 5001 cells/L. 5. Resistance testing. Perform baseline genotypic resistance, e.g., ViroSeq, if VL greater than 1000 copies/ml or if prior art exposure is suspected. Detect major mutations with greater than or equal to 15% prevalence. For patients with suspected opportunistic infection, high-resolution CT of the chest is the modality of choice, revealing ground glass opacities in 71% of PCP cases. MRI of the brain is indicated when neurocognitive symptoms arise. Diffusion-weighted imaging detects HIV-associated neurocognitive disorder, HAND, with a diagnostic yield of 84%. Key points: HIV-1 RNA, less than 20 copies/ml equals undetectable, 20200 copies/ml equals low-level viremia, greater than 200 copies/ml equals detectable. CD4 count, less than 200 cells/L equals AIDS defining, 200350 cells/L equals moderate immunosuppression, greater than 500 cells/L equals near normal. Complete blood count, hemoglobin greater than or equal to 12 g/dl, women, or greater than or equal to 13 g/dl, men, to avoid ART-related anemia. WHO clinical staging: Stage 1, asymptomatic, Stage 2, mild, Stage 3, advanced, Stage 4, AIDS. References. 1. Georgiadis and et al. Undetectable equals untransmittable, a cross-population systematic review and meta-analysis on awareness and acceptance. Pathogens, Basel, Switzerland. 2025, 14-7. PMID, 407327119, https://pubmed.ncbi.nlm.nih.gov/407327119. DOI 10.3390/pathogens 140706673. 2. Schweitzer AM et al. Addressing HIV stigma in healthcare, community, and legislative settings in Central and Eastern Europe. AIDS Research and Therapy. 2023, 187. PMID 38082352, https://pubmed.ncbi.nlm.nih.gov/38082352. DOI 10.1186/S12981-023-00585-1. 3. Koiner et al. Investigating the effect of undetectable equals untransmittable message frames on HIV stigma, an online experiment. AIDS Care. 2022, 34, 155-59. PMID 34292116, https://pubmed.ncbi.nlm.nih.gov/34292116. DOI 10.1080/09540121.2021.19564115. Thank you for watching. For the full article, visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.